Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center here in Fort Myers, Florida. Adjacent segment disease, which is a degenerative disease that occurs in the segment above or below a degenerative fusion or cervical fusion. We all know that fusion works because it stabilizes unstable segments. So if somebody has severe instability, say from L4 to S1, a surgeon might say, hey, your chronic low back pain is from instability, so we need to fuse the area. Well, anybody who's ever had that knows that initially, normally, it's effective at reducing pain, but then 3, 5, 7, 10 years later, some of the pain can come back. And often what's found is there's now degeneration above the fusion and below the fusion, and sometimes surgeons then extend the fusion. But I think there's a better way. One can stabilize the lumbar spine, thoracic spine, cervical spine by prolotherapy. And I'm going to just show you some X-rays and different things in a few of our patients to illustrate the fact that usually the pain after a fusion operation is because of instability above the level of the fusion or below the level of the fusion, and by stabilizing those segments with prolotherapy, the pain goes away. So that's a much better option than extending the fusion. And I would even say that anybody contemplating surgery, a fusion surgery for cervical instability or lumbar instability, please get a second opinion from a prolotherapist, and it may be that you're a good prolotherapy candidate. Because the thing about prolotherapy is you can always do surgery if prolotherapy doesn't work, and obviously prolotherapy helps the person retain some motion. And we all know that intuitively, to have the middle of the neck not moving, or the top of the neck not moving, or the bottom of the spine not moving, it can't be so good long term. It might be helpful short term, but it's probably not going to be good long term. So here's a patient with a fusion here, and if you look really carefully, right above the level of the fusion, there's a bone spur here, so the body's trying to stabilize this segment, and you'll see that when they bend forward, it goes like this. So they actually have, even with this bone spur here, they have instability right there. So that instability eventually is going to cause degeneration of the disc there, and that's what's called adjacent segment disease. And when they've looked at studies long term, it's basically very common after a fusion operation to get adjacent segment disease that's symptomatic. If you've had a fusion and it didn't resolve the pain, it's probably that you have other areas of instability that weren't addressed by the fusion, or if you had the fusion and got some symptomatic relief for a short period of time, or even for several years, but now some of the pain's coming back, you should get a motion scan to look at, is there instability above or below the fusion. So that was the patient that I said you could see that they're getting adjacent segment disease because of the big bone spur here that's above the level of the fusion. So it means that the body's trying to stabilize this. In other words, get a degenerative fusion here, and if the body's successful, there'll be an osteophyte that'll go from this bone to this bone. Well, you know what's going to happen then. Then this is going to get unstable, that's going to get unstable, that's going to get unstable, because joint instability is a progressive disorder. So this person, when they bend their neck, they can't bend their neck here. So where's the hinge going to be? The fulcrum of motion now is going to be here. Once this fuses, then when they bend their neck, the fulcrum of motion is going to go there, so then that area is going to get unstable. And then the pain occurs because there's excessive stretch on the ligament, and there are so many nerve endings in the ligaments. Then the ligaments there's a nerve impulse from the ligament to the muscles. That's why there's so much muscle tightness, and the muscle tightness can be very, very painful. And this is what you see on MRI, that these vertebrae are in alignment, but then there's a step off here, so you know that the person has ligament injury here or instability here, and that's also causing spinal cord tension. And when there's excessive motion of vertebral segments, that's when discs herniate. In my opinion, the cause of most disc herniation is cervical instability from ligament damage. This was a case that I consulted on from Europe. Look at, this is a young person that's like 15 years old. Yeah, 15-year-old. They've had 2 spinal surgeries, and look at this. Look at how much instability is now below the level of the fusion. So that's adjacent segment disease. And the problem is surgery, there's no turning back. See, that's why I think prolotherapy should be used before a cervical or lumbar thoracic fusion, unless it's an emergency, unless there's like a accident where the bones were broken or something and you have to stabilize it very quickly. Disc replacements, disc replacements. So here's the disc replacement, and then this is what it looks like under MRI. So adjacent disc disease, see how you can see on MRI, this is white, but this one's dark, this one's whiter. When the disc gets dark, that's adjacent segment disease. So what we would do with this patient is we would do a motion scan to see if there was instability developing below or above the fusion. And again, here's a lumbar fusion. So we would be looking at, is there adjacent segment disease below the fusion or above the fusion? And I know for certain that this disc space is low, that disc space is low, so they're already developing adjacent segment disease. This graph showing the association between the prevalence of symptomatic adjacent segment disease at each cervical motion segment and the amount of flexion and extension as described. Basically, this shows that the more there's motion in the adjacent segment, the more likely it is for that segment to be symptomatic. And again, in layman's terms, it means that ligamentous cervical instability or lumbar instability is the cause of symptomatic adjacent segment disease. And in my opinion, the treatment of that is going to be prolotherapy. And we all have to realize that there's certain motions, like sitting, people forget that there's actually more pressure on the lower back in sitting than in standing. And that's why if you're doing computer work, you really should have a standing desk because there's so much less pressure. And it's that increase in pressure on the ligaments that are above and below a fusion and the activities we do that cause those ligaments to be damaged, right? So even if a person had a fusion, if they get their musculature really strong and then they do activities that limit the pressure on those ligaments, they can decrease the incidence of adjacent segment disease. So that's why I just kind of have this one up there. And then basically, if you look at how much force it takes to injure ligaments, it's actually very little force to injure ligaments, and the ligaments that get injured the most are the capsular ligaments, and those capsular ligaments are what surround the facet joints. The facet joints are the parts of the vertebrae that move when we're moving, and so those are the most important ligaments, in my opinion, to strengthen with prolotherapy. Here's the capsular ligaments. So they've shown that basically when these ligaments are injured and there's instability here, that causes degenerative disc disease. If you've had an MRI and they say, oh, the disc above or below a fusion is now all degenerated, it's likely that you have posterior ligament injury, and that needs to be treated with prolotherapy. Now, one of the things that causes these ligaments to stretch out is slouching. So technically, in this chair, I should be sitting like this. So if I slide down and now I slouch like I'm like this, like how many people are watching TV like this? Like this is terrible for my capsular ligaments that stabilize my facet joints, and this is terrible for my lower back. The lower back spinal curve is normally lordosis. It's normally lordosis. So when you slouch, you reverse the curve in the neck and the lower back, and that stretches the ligaments, and it's stretching of the ligaments that is responsible for adjacent segment disease. So if you, again, have had a spinal surgery and you don't want to get another surgery or get prolotherapy, then contract the muscles, sit up straight, have good posture, especially while working, and you're going to decrease the forces and hopefully keep your capsular ligaments strong. And again, remember, ligament injury is a progressive disorder. You get one screw is loose, then you open and close the door, the next screw is going to get loose because the force goes to the next screw. Once this hinge is loose, it goes to the second hinge. Once you fuse the joints, now the force goes above and below where the fusion is. Those ligaments get loose, just like the loose screw. Then the next ligaments get loose and it goes up and down the spine. That's why it's a progressive disorder. The better option is don't even get a fusion. Try to get prolotherapy before you sign up for a fusion. But if you've had a fusion, then, and you have some pain after the fusion, then consider getting some type of motion scan to show the instability. And they now do flexion extension, lumbar and cervical MRIs. They're pretty good. And of course, fluoroscopy or digital motion X-ray, of course, is what we use to document the instability. And then prolotherapy is done into the ligaments that stabilize the vertebral segments. Prolotherapy causes a thickening and tightening of the ligaments to cause stabilization of the segments, and mostly what we're treating is the capsular ligaments. So depending on which vertebral segments are affected, those would be the areas that are treated with prolotherapy. And I have a variety of cases that I've treated over the years, and this particular patient did extremely well with prolotherapy.